for computing the survival fraction of cancerous cells. The basic equation is this, but this equation has been developed and includes another factor which is called G. And this factor depends on several factors that must be determined. It depends on the recovery time and the half-time of sublethal damages. And we computed these factors in our study and implemented it on the cancerous cells. This equation was used to calculate the G parameter, which is used as a parameter to compensate the prolonged delivery time. And by determining the survival of the cell lines and also given a dose and knowing the alpha and beta, we can find the G factor for any cancer cell line, as we did in this study. And because of the shortage of the time and the complexity of this formula, I go through this slide. Okay, how did we do that? A cobalt-60 unit made by Imatron from Canada was used as the radiation source. The ionizing radiation was delivered in a 25 by 25 square centimeter field size, and the source half depth distance was calculated to obtain a constant dose rate of 0.85 gray per minute. All the radiation procedure, as you see in this slide, was performed at a distance of 20 centimeters between the source and the plates in which the cells were located. And a 4 centimeter block was used to provide a uniform dose distribution. And we did our experiment on 2 groups of cells, including themselves from several groups. In one group, we used the conventional method without compensating doses. We gave continuous doses of 2, 4, and 6 gray in a single fraction in one group of the cell lines. And the same level of doses was given in 2 fractions. And these 2 fractions were implemented at different time intervals. 2.5 minutes is the conventional time that is used for a single fraction, and we also gave this radiation at a quarter of an hour, means 15 minutes, half an hour, 1 hour, 2 hours, 3, and 4 hours after the first fraction. And even though a 4-hour time is not very common in normal procedure, and the maximum time normally is less than 2 hours, we actually continued our study to investigate whether there is any effect, and if there is any effect, whether we can compensate this effect by calculating the compensating doses. As you see in this slide, it shows the survival fraction for the 2 kinds of the cancerous cells, including the adenocarcinoma and the melanoma and breast adenocarcinoma. And these two graphs show that this cell line is more sensitive to radiation. As you see, the survival fraction goes down rapidly, more rapidly than this one. From these curves, we calculated all the parameters needed in those equations I showed you, including alpha, beta, and the half time for sublethal damage repair. And whenever these actually parameters are lower, it shows that the cell line is more sensitive, and the 41 breast adenocarcinoma is more sensitive than the melanoma. And this is the final result. As you see, this is the control. it means that the cell line that has not been given any radiation, and it is the survival of the number of the cells. And this is the normal procedure that is carried out in clinic, a single fraction. And the next bars show, for example, 2 gray given in 2 fractions from 15 minutes up to 240 minutes. And this is for 4 gray doses given in 2 fractions at different time intervals, and this is for 6 gray. These 3 sets show that for this cell line, which is the melanoma, at 2 gray, the delay does not make any significant difference. But if the dose would be 4 gray and is given at different time intervals, the survival rate is less when there is more time delay. And for 6 gray also there are significant differences between the groups. And for the other cell line, which was more sensitive, it was the 41 breast adenocarcinoma. Even at 2 gray, if we give the 2 gray, which is a single dose given at a session to a patient, but there would be delay from 15 minutes up to 240 minutes, the level of the cells that would keep alive will be higher, even at 2 gray. And at 4 gray and 6 gray, we see the same effect. But as you see in all of these figures, after 2 hours, there is not much difference. It means that before 2 hours, there is significant difference, but after that, we don't see. Therefore, various fractionation regimes and increased treatment time, as used in this study, make no significant difference on the survival fraction of melanoma cancer cells at 2 gray dose. But at higher doses, including 4 and 6 gray, there was significant differences. But for the most radiosensitive cancer cells, which was breast adenocarcinoma, increasing the treatment times at all 3 dose levels of 2, 4, and 6 gray make significant differences. And at higher dose levels for both of the 2 cell lines, the increased time intervals up to 2 hours causes an increase in the survival fraction of both of the cells, which is higher for the 41 cell. And it is attributed to the lower alpha to beta ratio and shorter half-life for the sublethal damage repair. This slide shows very significantly the effect of implementing the compensating doses that we calculated from dose complex equation by determining dose factors. As you see, the top curves show the normal procedure that is routinely nowadays used at hospitals. It means we give fractions without any attention to the delay between 2 fractions in complex systems. And as you can see, the survival rate of the cells go up if the time increases from 50 minutes up to 2 hours. But if you calculate the compensating doses as we did in this study for any situation by determining those parameters, for example, instead of giving 2 grays in 2 sessions, we gave 2.7 grays after 50 minutes. And for 30 minutes, we gave 2.15 grays after 30 minutes. And for 3 hours, we gave 2.37. But thereafter, there was not very significant differences between the level of doses that should be compensated for. And as you can see, if we implement this technique, it means that if we calculate the compensating doses for these delays, we can keep the cancer cell survival fraction down. It means that the cancer is treated better. As the discussion, you may ask, what is the reason for increasing the cancer cell survival fraction treated with prolonged treatment time? It is thought to be due to the sublethal damage repair, as I mentioned, and occurred during the time intervals between either the conventional fraction or more complex subfractions in modern radiotherapy procedures. And I should also point out the limitation and restriction of the formalism used in our study. This study was proposed for the generalized incomplete repair model. Therefore, there are other models that investigators can try. And it is based on the developed LQ model, linear quadratic model, radiobiological model, and is limited to constant exposure time and time intervals. It means that if the exposure is not constant, you cannot use this technique. It is just appropriate for this technique. And it is believed that the developed model reflects a cell capability to repair sublethal damages when fractionated delivery time is comparable or longer than the half-time of sublethal damage. Therefore, not for all cancer types, this can be done. And also the dose rate effect are included in this model. The so-called dose protraction time G, which we computed. And it depends on the cell type, and it should be determined for any cancer type. And in conclusion, from the two-cell cancerous cell line, we studied the 41 breast adenocarcinoma cancer cells having lower alpha to beta ratio and half-life for sublethal damage have larger ability to undergo the sublethal damage. And the effect of prolongation of the treatment time in complicated radiotherapy modalities is expected to be significantly higher in the tumors with lower alpha to beta ratio, which demand more attention. And for the higher time intervals, more than 2 hours, we noticed that there is no significant difference and the difference is negligible. But for the time intervals less than 2 hours, which is commonly used in clinical routine radiotherapy practices, increasing the time intervals between subfractions increases the survival of both of the cells, but at a higher rate for more radiosensitive cells. Therefore, the result confirmed that exposing the fractionated groups to the additional level of compensating doses instead of conventional ones decreases the percentage of cell survivors, cancer cell survivors, to the same level of the group exposed continuously to the common dose levels without any delay. Therefore, by using the developed LQ model I introduced in this presentation, the exact amount of compensating dose to achieve the same survival as conventional radiotherapy protocols could be calculated and used to increase the treatment efficacy of modern fractionated radiotherapy protocols such as IMRT, IGRT, IORT, which are becoming more common. Thanks for your attention. And for your patience. If you have any question.
Open for questions.
Thank you, Doctor, for your nice presentation regarding radiotherapy procedure. I have a question. Is there any study regarding brachytherapy to the site of melanoma as well as adenocarcinoma of the breast? Have you got any brachytherapy study? You have given all the teletherapy.
Actually, we did this study on the cell lines, not on the patients. But at the next stage, it should be done in clinical situation, a clinical trial should be done. But we highly recommend this because in radiotherapy department, normally oncologists and physicists use the conventional method, and they don't regard the delay between the subfractions in these complex modalities. Therefore, based on this, if we can find the effect, the compensating doses for each kind of cell that should be done, therefore we can implement it clinically.
Okay, thank you. I have another question, please.
Yeah?
You are using your radioactive substance cobalt therapy.
Yeah,
Cobalt?
yeah, we use cobalt, but we simulated the cobalt with the same as IMRT. It means that we gave the fractionation in the way that is used in IMRT. We produce the delay that happens in IMRT or IGRT, but we use the cobalt. Because with the LINAC, it is very difficult and it is costly. But with cobalt, you can simulate that situation. Okay. But somebody else can do it with the LINAC if the clinician give you the access to the LINACs. Yeah.
Okay, thank you. Thank you for answering.
Okay.
Just a minute.
Okay.
Thank you for giving me chance. Okay. From your explanation, and as far as I know, radiotherapy is mainly used for cancer therapy. So I would like to know what is the benefit of radiotherapy comparing with surgical therapy. It is my first question. And I heard that radiotherapy, more on clinical really my questions, radiotherapy can reduce the life expectancy of the patients due to reduced self-immune response. What is your opinion? Okay, thank you.
As you know better than me, I am not a clinician, I am a physician, but no treatment is ideal. Radiotherapy is used in addition to the surgery or in conjunction with surgery and chemotherapy for patients. All of these modalities are complementary. Therefore, there is no definite cure. But in some cases, you cannot do surgery. And you have to do radiotherapy to actually provide more life for the patients and keep them more alive. And also radiotherapy is used as a complementary for irradiating patients who have had already surgery for killing the cell in the place of the tumor. Or it is used in conjunction with chemotherapy. With chemotherapy, you make the tumor shrink, then you use radiotherapy and you kill all of the tumors. Even the radiotherapy itself is not 100%, but you can take up the life expectancy of the patients. And regarding your next question, these modalities that I introduced you, which includes IMRT, IGRT, and also IRT, all of these modalities have been developed to better conform the radiotherapy to the place of the tumor without damaging other structures. But on the other hand, the case of this study was that these modalities are complex and they take time. And if you are going to use these modalities, it is better to pay attention to this factor. And you do not use the previous methods without compensating doses. I meant that instead of giving two equal fractions, because fractionation is done for protecting patients. You give it in two fractions, for example, in 1 day or 2 days. Or one fraction is given in many sub-fractions. And because of this, it is better you calculate the compensating doses and give more radiation to kill all of the cancer cells.
Thank you, Dr. Bijan. Thank you.
Okay.
Thank you very much, Mr. Chairman, and also to the presenters. Can we give them applause? Ladies and gentlemen, I think we have come to the end of the day. But to show our appreciation, I would like to invite Mr. Idris Ahmad, the Head of Quality Assurance, to present the token of appreciation. Mr. Idris, please. Accompanied by Datin Hafiza. Welcome, Dr. Widyawati Wijakosono.
Yes.
Dr. Bijan Hashimi. And Associate Prof. Dr. V. Gopalakrishnan. Forward with smile. Okay. Thank you, Mr. Idris, Chairman, and the presenters. It looks like we have come to the end of the day, but we'll continue tomorrow. We'll be in here sharp at 9.